instruction do's and don'ts. My name is Dan Green. I'm one of the senior faculty at ExamPro. It's my pleasure to be with you today. So I've been with ExamPro for more than 20 years, and in that time have reviewed well over 600 case lists personally. In addition, not to mention the literally thousands of candidates for whom we've done mock orals and have had an opportunity to look at least a portion of their case list in preparation for the mock oral and during the mock oral. My goal today is to try to help you, one, save some time as you put together your list, and at the same time, not make mistakes which come the day of the test or as you start studying more or start studying in earnest for the exam, you'll wish or realize that you would have listed a particular case differently, or perhaps not even listed a case at all in the case of an office section. All right, so hopefully this will encourage you to get an earlier start on your list. The earlier you can put your list together, and if you decide to have it reviewed, get it back, incorporate the suggestions if you agree with them, and submit the list, the more time you'll have to study. This is particularly important for the 2023 testing period. As you know, ABOG has condensed the time period for the exam. So for example, the late submission of case list is middle of August. Yet some people will be taking their exam in the middle of October. So it doesn't give you a tremendous amount of time for preparation. Therefore, getting this case list out of the way earlier will certainly bode well for your ability to prepare adequately for the exam. All right, so let's move on with the discussion. So the first thing, I would strongly suggest that you have your case list reviewed before you submit it. I can't tell you how many candidates each year when we're doing mock orals with them, and we point out a particular case or how it's listed, how many people say, oh, I wish I had listed that differently. Or they recognize that there's a problem with a particular case, especially the way they've listed it, which they couldn't appreciate when they were actually compiling their list. So again, the case list is the first impression the examiner is going to have of you, even before they ever meet you. They'll be looking at your list the night before they go to test you. So it's really important to make that first impression as good as you can. As I mentioned, we've had folks every year, we run into people that wish they had had their list reviewed beforehand. So in the review, we're not just actually looking, did you have a spelling error? How did you list this particular case? We're also trying to help to suggest questions that may be asked of you as it relates to a particular case, which will help you in your studying. And if you think about it, some people say, oh, I can read through my list myself, and I'm sure it'll be adequate. And, it will be adequate. And if there's a problem, you can, if you discover the problem before you're actually in the midst of the exam, you may have an explanation for it. But think about it this way, if you were in college and you're trying to proofread a paper, your own paper, it's very difficult. There's nothing like having a second pair of eyes, check for spelling mistakes, grammatical mistakes. And in this case, not just those situations, but also, did you do a certain thing for a patient before you took them to the operating room, or knowing some other relevant facts, or perhaps even listing these on your list. Again, proofreading your own paper, your mind, you know what you intended to say. In the case of your case list, you'll know the background of the patient, but that doesn't always come through in how you've listed a particular candidate. Listed a particular patient, in that the examiner may not be able to piece together what happened based on what you've listed, and that can be important. Okay, so a couple general principles. When you're putting your list together, and actually when you're defending your list, you never want to be dishonest. I'm sure you wouldn't consider that anyway, but just to put it out there. There are some gray areas, however, and by that I mean You don't necessarily have to list every single radiographic study that was done on a particular patient or every lab that was done on a patient. So there'll be situations where your patients were referred to you with, MRIs or CT scans that maybe you wouldn't have gotten. It may be relevant to list, or maybe it's not. You may have a 25-year-old that had a 2 centimeter cyst that was referred from her primary care provider that had every tumor marker under the sun. Now, again, in this situation, you didn't order them. You could list the tumor markers and always just verbally explain these were obtained prior to sending to you, the patient to you, that is. Or you may choose to leave them out altogether. There are going to be things that you do that you don't list on your case list. For example, I'm sure all your patients, you take their blood pressure, but you're not listing blood pressure on the list unless it's relevant, like in the case of a chronic hypertensive OB patient or a chronic hypertensive GYN patient that you're considering contraception, or obviously a preeclamptic patient. So again, there are going to be plenty of things that you do that you don't list on your list. So you want to be kind of strategic about what you choose to list and what you choose and what you decide not to list. Um, so, using the same scenario, if you had a 25-year-old who had a 2 centimeter cyst and for whatever reason you got tumor markers, that may be something you choose to leave off the list. Now, if they said to you, did you get tumor markers during the test? Of course, I would be honest and say, yes, I did. This is the one I got. But again, you don't necessarily have to list that and include it on your list. Next thing, a patient can only be listed one time on any list. That's not one time on each section. So once on OB, once on GYN, et cetera. This is one time period. So if you have her on your GYN list because you operated on her in the operating room or at the surgery center, you cannot list her on your office section. Similarly, if a patient delivers, you may want to put her on, and she had a complication with the delivery, like even something as mundane as delivering it, before 39 weeks, that patient should be listed on the OB list. If she subsequently had a GYN surgery, again, you'd have to put that on the OB list. Now, if your partner did the delivery, let's say at 38 weeks, even if you provided prenatal care, that's a different story. You can then list that patient on your GYN list because someone else did the delivery, even if you provided prenatal care for her. But if she were admitted or in any way should be on your list by virtue of having your name to an inpatient encounter with the patient during her OB time, she should be listed on OB, and you can put the postpartum tubal or laparoscopic tubal ligations, 3 month status post SVD. Again, if you didn't do the delivery, but you just provided outpatient prenatal care, by all means, that patient is fine to put on the GYN list. So again, it gets complicated more so if you've done the delivery and you've done a GYN surgery on her. You also, of course, cannot list that patient on your office list if they're either on the OB or the GYN list. When you are a quote unquote surgical assistant, so you're not a co-surgeon, meaning you did less than 50% of the care provided, even if you did your side of the surgery, but you're listed on the operative note as a surgical assistant instead of a co-surgeon, that would not be a case I would list. First of all, maybe you took ovaries on a 40-year-old, just making this up. Maybe you didn't. And if it's your partner's patient and you're kind of scrubbing in and they, and you really didn't have any say in it, and again, you're not a co-surgeon, but just a surgical assist, that would not be a case I would want to defend because you had no real input. If you're doing your side and you're doing either pre or post-op care on the patient and you're listed as a co-surgeon, by all means, this patient should be listed on your list. If you didn't do the entire surgery, let's say you do a hysterectomy and you have a urogynecologist do a suspension suture. Again, you would still list the hysterectomy, of course, and you could put, urethral or urethropexy by urogyn. Or you could list the urethropexy, not list by urogyn, then be incumbent upon you to mention it verbally if the case would come up. Personally, I would recommend listing by urogyn in that case. Doesn't get you off the hook for knowing about the procedure, but you wouldn't need to know it necessarily in quite the same detail. All right, so the next thing I have listed here is less is more. What does that mean? Well, I've had people who have, and we'll see some examples where they list a novel for each patient. It's extremely tedious for the examiner to get through that case list and try to identify cases that they want to query you about during the exam. So it's better to be high level when you list your cases. For example, instead of listing every PCOS lab that you may have ordered for a patient, much better to list something high level. It says PCOS labs. If you list that, you can imagine the examiner might say to you, well, when you have a patient that you suspect has PCOS and you're doing a laboratory evaluation, what labs do you get? Well, that's a pretty easy question to answer. So if you list every single lab, they're not going to ask you basically to read your list to them. They can read just as well as you can. And it ends up acting as a crutch for you because you're afraid you're not going to remember them. I would encourage you again not to list every single lab. Um, so again, high level PCOS labs. If we're talking about a particular medical condition, like an OB patient who's, let's say, a pregestational diabetic, rather than listing that you got a baseline 24-hour urine ophthalmology consult, echocardiogram in the second trimester, baseline preeclamptic lab evaluation, hemoglobin A1C, and then, you could also argue that I'm sorry, let me back up. What I would put is diabetic management. Now, diabetic management even could include things such as increased antenatal surveillance later in pregnancy. It could include growth scans, or you may choose to list those separately, like growth scans and increased antenatal surveillance. But I would definitely not mention, ophthalmology consult, EKG if you got one, and the second trimester fetal echo. Again, unless there's a problem with it. If the fetal echo showed a cardiac anomaly, by all means, I would list it. Same thing goes true for hypertension management. So if you have a patient who's a chronic hypertensive, don't list every single thing you did for the patient. Just put hypertension management because that promotes discussion and you can talk about what your typical hypertension management includes, including perhaps, putting the patient on aspirin. Now, some people will decide to list aspirin, for example, separately. That's your choice. Personally, I would include it for me under hypertension management. But if you want to list aspirin individually, because it's a little bit different than, having to do with labs and testing, by all means, you can list it. And in the end, you're going to have to choose what you list and what you don't list. These are strong suggestions from me. It makes the list more easy to read, and it also promotes some more basic discussion areas. Okay, some more rules of the road. So let me explain to you how this works. So you submit your list to ABOG, it gets approved, they assign you a date. The examiner will be given your list. So let's say it's a GYN examiner. They will be given your GYN list the night before you take the test. Now, unless your test is on a Sunday, unless your test is on a Monday, I should say, they will have spent 6 hours that day examining other candidates. So they have 3 candidates in the morning, 3 in the afternoon. Each section is approximately an hour. So they're going to have spent 6 hours listening to candidates and what have you. And then on top of that, that evening, they have the opportunity to review your list plus 5 others in anticipation of the exam the next day. So you can imagine it's a rather long day for them. I would encourage you as a result to make it your list as reader friendly as possible. Remember, they're formulating an opinion of you before they ever meet you. If you have 50 hysterectomies, I'm exaggerating and making this up, of course, on patients that were 30 or younger, all for chronic pelvic pain, let's say 90% of them had no notable pathology, a uterus of 90 grams and no fibroids or adenomyosis or whatever, they're going to look at you the night before as an aggressive surgeon. So, that's kind of air quoting here, a hole you've got to dig yourself out of the next day. If your list is sloppy and has a lot of typographical errors, again, not 1 or 2, everybody has that, even after making their best efforts. But if it's really poorly written, you're missing a lot of information like type of delivery and what have you, and it's just sloppily put together, they're going to think this person didn't take the exam very seriously. So I'm not saying you're going to fail automatically because of that, but they're going to have a negative opinion of you when you walk in the next day or when you're on Zoom, if depending how the exam is given next year. So you really want to make your list very readable. You want them to be able to piece together what happened with a given patient based on what you've entered for the case when they review the case. So are tumor markers critical? Not necessarily, especially if they're negative, but they're going to want to see like chronic pelvic pain, failed medical management, maybe, or desired definitive treatment, something that gives them a picture of, okay, this is the patient I had, this is the workup I did, these are the options I discussed with her, this is what I ultimately did, and so that they can put it together. They may not have every detail, but still in all, you want to make sure they have an understanding why you did what you did. And again, high level, you can certainly fill in the details the next day, although they're not going to ask you to present a patient, but they may ask you, how come you did a certain procedure laparoscopically when she had a small uterus? And again, we'll talk about that in a minute. So when you're listing a particular patient, again, try to be concise as much as you can. Don't use a lot of extraneous information. I've had people that put in so many things like, they put in their patients having a hysterectomy for abnormal uterine bleeding. And, they put in that the patient drinks three drinks a week or something like that. I'm, again, exaggerating. Or maybe the patient has well-controlled lupus. Well, I mean, again, if the patient had a wound separation, whatever, was on steroids, obviously that can make a difference. But if they're well-controlled and not on medications, it's not critical. Excuse me. Now, if you have a very short list, so let's say you only have 22 GYN cases, you may want to add some of this extra information because it will promote discussion. But if you have a normal size list, we really don't want to have a lot of extraneous information. So again, smoker over 35 relating to contraception counseling. That makes sense to list, if the patient's coming in for contraceptive management and you put tobacco use, makes sense. Hopefully you would also put in there tobacco cessation counseling in the treatment, but that's another story. If the patient were 25, is it critical to list smoking? I mean, would birth control pills be contraindicated? I would suggest not, again, unless you want to discuss the topic of smoking cessation. A patient, for example, with a vulvar folliculitis, very unlikely to affect your management of abnormal bleeding. I probably would leave that out unless that was the primary thing that she came in for. All right, so this next point is extremely important. When you compile your list, keep a page, so a notebook, off to the side that says GYN patient number 1 and put the pertinent positives and important negatives. So just a minute ago, I was talking to you about that. Why'd you do a TLH on a patient? Let's say that's a para 2, and she's got, the uterus turns out to be 120 grams. So why'd you do TLH instead of a TVH? Well, it could be those 2 prior deliveries were C-sections. Some people put that on their list and some people don't. Personally, I would suggest not putting it on the list. That way they might ask you about it, but this would be a situation where you need to know the pertinent positive in this case, and that is the patient's had previous abdominal surgery. So, I'm not talking about putting the whole patient's history and physical and every single thing on in this notebook. Way too much information. You don't need to know that she was 2 months late for her MMR shot when she was a child. So you don't need to know every single thing, but there are certain pertinent positives that you would need to know. Example, family history of ovarian cancer. That would be a pertinent positive if you don't note it on the list. That would be important, particularly if you took the patient's ovaries at an earlier age than you might otherwise have done so. So again, anything that would be important to mention. I'll give you another example. If you do an endometrial ablation on a patient, you don't list any form of contraception that the patient's using. Let's say the patient has had a tubal ligation in the past, or maybe her partner's had a vasectomy. Well, that would be a pertinent positive to be able to recall right on the spot if they ask you what's the patient using for contraception. If you hem and haw about it during the exam, then they're like, well, does this candidate really remember what happened? Are they making this up? What exactly is going on? So, again, having these facts at your fingertips, and I'm not saying you would take this notebook obviously into the exam, you can't, but you can use it to practice from. So, again, I'm talking about in some cases, no additional information. In other cases, there may be one or two other things that are important to remember about a particular patient. All right, so the next part is spot the mistake. So we're going to look at about half a dozen scenarios, and I'm going to point out to you how people have listed things in their case list. Some of these examples will show good technique, and some are going to show bad construction technique. And again, if you can look at something and go, hey, this doesn't make any sense to me, or this really is a mistake, you're much less likely to make the same mistake as you compile your own list. So let's look at this first scenario. I'm just going to pause for a second to let you guys read this. So as you can see, all three patients want permanent sterilization. So, first patient has a seizure disorder that complicated the previous pregnancy. That would be something I would suggest would be, one of those pertinent positives that I would verbally bring out. But if you want to list it because you're afraid you're going to forget it, fine. Is that a complication? Is that a contraindication to future pregnancy? Probably not, but it certainly would make her a little bit higher risk. Schizoaffective disorder. Now I'm starting to wonder, well, does she need to have a psychiatrist? I don't want to say sign off, but attest that the patient's competent to make her own decisions, especially with the borderline personality disorder. Is this absolutely relevant information for her to make a decision about sterilization? Does it have anything necessarily to do with the case? If she's competent, I would suggest no, it doesn't. Maybe the seizure disorder I would include, but I really wouldn't include schizoaffective disorder and borderline personality because the subject is tubal ligation. And unless you want to talk about some of the mental health aspects, I would leave them out. Similarly, I would suggest for the asthma. Now, if the asthma required the patient to be in the hospital overnight, by all means, I would list it. But if she just required a nebulizer, post-op, perhaps and pre-op, I mean, is that really absolutely relevant? Did that change in any way or affect this particular patient's care other than, of course, receiving the nebulizer? All right, so there's a bunch of stuff here I would not personally put in. Again, the seizure disorder perhaps, but the rest of the stuff I would personally leave out. Now, if we look at the treatment, let's look at all three patients. The first patient says counseling regarding post-sterilization regret. So all patients should be counseled regarding post-sterilization regret. That would be part of informed consent. So I would argue that would definitely not be something I would include with this patient. Did they put it in because she's only a para 1 and she's at higher risk of regret? And also she's 29? Well, patient number 3 is 29. Did we not talk to this patient about the risk that she might have regret given her age? Again, it's making assumptions. You could have a nulliparous patient, which we know would be at higher risk of regret, but your counseling should be the same. And your procedure should be the same. If you're going to do a salpingectomy, you should do a salpingectomy. If you're like, well, she might want it reversed, she's a higher risk of regret, well, then don't do the tubal if you're not convinced that she's absolutely certain under no circumstances does she ever want to have children. So again, it's important to be consistent. The examiner is going to go, well, when this doctor counsels regarding regret or sterilization regret, so, counsels patient about the permanency of tubal ligation, they list it because look, he or she listed it for this first patient. They didn't list it for the other two, therefore they must not have counseled those patients. In other words, if you list it for one but not the others, they're going to figure patient wasn't counseled. Similarly, patient number 2 on this list, they were counseled regarding vasectomy. So was patient number 1 not told her partner could have a vasectomy, or for that matter, patient number 3? it's very important to be consistent. If you list something for one patient, but you don't list it for other patients, it's going to be construed that you didn't do it on the other patients. They're going to go, when the doc does it, the doc lists it. It's not listed, ergo it was not done. You could say, oh, no, of course I tell all my patients about vasectomy. Well, do you, or now are you just kind of covering your tracks? So the consistency would be the big issue here, as well as the additional information that's provided for patient number one. My suggestion would be just to put, if you want to do contraceptive counseling and list it for every one of them, fine. If you don't, which I would think you don't need to, I would just put the laparoscopic tubal ligation. I mean, if you look at number 2, they don't even have a procedure listed. So technically speaking, this patient doesn't even belong on the GYN list because there was no surgery done. That's what I mean about not being complete. And, I'm sure this candidate, when they looked at this list, they were like, oh yeah, of course, this patient had a tubal ligation. She's listed under tubal ligation. Well, that's great, but there's no tubal ligation listed here. And that's not something you can leave out. Even though if they're under the category of tubal ligation, you've got to list the procedure. So consistency, too much information, and not listing and missing information would be what I would suggest for these 3 patients. All right, let's look at the next one. So 42 weeks, gestational diabetes, failed induction, primary C-section for failure to progress. So what's wrong with this? First of all, why is a gestational diabetic going to 42 weeks? That'd be the first thing I'd ask. Failed induction. What's the definition of a failed induction? Failed induction, by definition, is not failure to progress. Failure to progress is slang and not an acceptable term, and you want to have acceptable terms on your list. Really, what it would be is arrest of dilation or arrest of active phase. So someone can't have a failed induction and have an arrest of active phase of labor. Failed induction means we didn't get her into labor. Arrest of active phase is something different. It means she was 6 centimeters or more with no change after 4 hours with adequate contractions, or 6 without. I would further suggest to make that diagnosis, the patient most likely had an IUPC. So that would be something very important to list. Similarly, how long did the candidate induce this patient? Because she had a 3-day length of stay with a C-section, and the baby had a 3-day length of stay. So looking at the length of stay, I'm thinking, well, did they really give her a full 24 hours? And if they did, how do we come up with only a 3-day length of stay and the baby had a 3-day length of stay? So we have incorrect terminology here. There's no comment about the diabetes being managed. So diabetic management, or increased antenatal surveillance, or anything as it relates to the diabetes growth scan. I'm not saying you have to list everything, but diabetic management would capture it all, and then you could branch out and say what that would include for a gestational diabetic. Maybe she's super well controlled. She's a super well controlled A1, but I'm sure they were still checking at least finger sticks, and I'm sure they still did at least a growth scan. So, bunch of missing information here, contradictory definitions, length of stay is incorrect. And when they're looking at this list and they say, oh, failed induction, failure to progress, does this doctor even know the definition of the 2 terms? Again, please don't use failure to progress on your list. It's a slang term. It's not an appropriate diagnosis. It would be arrest of dilation or arrest of active phase. You can use those interchangeably. I would suggest picking one and not more. But all right, so the next case, pelvic pain, menorrhagia. She had a hysterectomy, cystoscopy. All right, so there's a whole bunch of stuff if you look at this. If you look at this slide. Pelvic pain and menorrhagia. So where's the pre-op endometrial sampling? I would argue that if a patient is having bleeding and that's one of the indications for her hysterectomy, you should have done an endometrial biopsy, and you should list the biopsy if you've done it. If she had a DNC instead, because maybe she had stenosis, who knows what, that's fine, but some sort of preoperative endometrial sampling. Now, the next thing is, if somebody has pelvic pain and heavy bleeding, I mean, do we just routinely, hey, I've got a spot tomorrow, I can do your hysterectomy? No, I mean, hopefully the patient was, tried on medical management, certainly at least offered medical management. Maybe she desired definitive treatment. Okay. But still in all, she should have had some preoperative endometrial sampling. Now, the next question is, Why was this hysterectomy done abdominally? I mean, the uterus only weighed 160 grams. She's para 4. Now, maybe they were previous C-sections, but it's not listed here. So that would be another question that's not consistent. The bilateral salpingectomy, this list probably was developed before the recommendation to do that. So I'm going to leave that off for a second. But then the next thing, focal high-grade squamous intraepithelial lesion. First of all, that should be the HGSIL is more of a cytologic diagnosis than it is a pathologic diagnosis. So that's one kind of weird thing here. I would expect it to say focal CIN2 or 3 or whatever. But how come we're finding that incidentally on the pathology? Now, it could happen, but in that case, I would want to know, was the patient up to date with their pap smear? So in this case, given that she had some unexpected cervical pathology, I would list in the pre-op diagnosis pap smear normal. Now, normally I wouldn't suggest listing pap smear for all your cases, especially unless they're abnormal. But in this particular case, as the examiner, I would want to know, was the patient up to date with her PAPs? Was it known that she had dysplasia? And if she did, did the patient have any excisional procedure before doing the hysterectomy? I mean, how do we know she didn't have invasive cancer? So there's definitely a bunch of stuff missing from this. Now, I will say the way the pathology is listed with, benign 160 grams, that is concise. And generally speaking, I would agree with how that's listed. They may have decided to include endometrium and just put benign. And if they had done the fallopian tubes, maybe they just put endometrium / fallopian tubes benign. But don't get into a whole heavy lift in terms of the details of the pathology, unless it's meaningful pathology. Knowing that someone had squamous metaplasia of her cervix, I could care less about. All right, so let's look at this case list. Can you imagine reading a list that's full of patients like this the night before your exam, or the night before you're going to query a patient, query a candidate for their test? I mean, you'd want to stick pencils in your eyes. So let's look at the first one: abdominal pain, fever and chills, postmenopausal status, suspect early appendicitis, and admitted by general surgeon. No response to IV antibiotics. Complete cystic pelvic adnexal masses up, or complex cystic pelvic adnexal masses up to 9 centimeters with internal debris on ultrasound. Suspect bilateral TOAs, ovarian neoplasm, endometriomas, large hemorrhagic cysts, normal levels of tumor markers. I mean, holy cow, this is a novel. This is not a listing. This is almost full sentences. So on top of it, they put their whole doggone differential in there. I mean, the differential is something they're going to want you to form and be able to discuss, listing every possible thing that it could have been. Not only are you cheating yourself, but you're frustrating the examiner. So this is listed very poorly. I would suggest that a better way to list it would be something like abdominal pain, febrile, concern for appendicitis, but refractory to antibiotics, complex cystic masses, 9 centimeters, complex bilateral cystic masses, 9 centimeters. Next line, if you want to put tumor markers normal, so be it. And then IV antibiotics, exploratory laparotomy, could put LOA, lysis of adhesions, you could abbreviate it, and then the BSO. Now look at the pathology. Left ovary with infarction and benign cyst, 8 by 7.5 by 6 centimeters. I mean, do we really care that it's 8 by 7.5 by 6? What if it were 8 by 7.9 by 6.2? Would that change anything? Of course not. So my suggestion would be, I would put benign cyst and I would just put 8 centimeters. Definitely don't get down to the millimeters when we're talking about size of ovarian cysts. Endometrial lining, yes, not size of ovarian cysts or size of the uterus. Right ovary with infarction and benign cyst, again, round it up or round it down. I'd say 8 centimeters and call it a day. I would say right adnexa with infarction and early ischemia. or signs of infarction and early ischemia. Again, trying to make it a little bit more brief. And if we look at the patient that they have listed as 23 at the bottom of the case, severe right lower quadrant pain, fever, leukocytosis, known past history of PID, bilateral hydrosalpinges. I mean, why not just say here that the patient's being admitted for, severe abdominal pain, concern or suspect and PID, or if you thought it was a TOA, the history of PID in the past. Yeah, I mean, it's relevant, but that's something I would verbally bring out. The bilateral hydrosalpinges, that's reasonable to list. But again, this could be done in a more concise manner. All right, spot the mistake. I gave you guys a great hint up here. Now, if you look at this list, it's pretty easy to read. There's a space between, there's one diagnosis for each line. So you see abnormal bleeding, then the next line, cervical polyp, and they actually skipped a line between the two diagnoses. Makes it much easier to read. We look at the second patient. The failed medical therapy, I would suggest, goes in pre-op diagnosis. I understand that that's a treatment, meaning the medical therapy, but it's usually how did we get what did we do before we got the patient to the operating room or to be admitted to the hospital? So in this case, the failed medical therapy, and then would go in the pre-op. Now, if somebody's admitted, like the previous case we talked about with the IV antibiotics that they received in the hospital, that's obviously a different story. So that would be my only criticism about this patient. So on patient 16, the failed medical therapy, I would have moved to the pre-op. 17, same thing here. 18, I would put the pelvic ultrasound in the pre-op. And quite honestly, unless the endometrial biopsy were done during the hysteroscopy D&C, I would list that in the pre-op. If it were done in the operating room, then it's appropriate where they listed it. Patient 19, I don't know that we need to put fallopian ring, but certainly not wrong to put it. But how they've listed the tubal ligation in this case, I think is terrific. All right, so let's look at this particular case. We could spend the whole lecture actually on this case if we chose to. If you take about 5 minutes, because that's maybe how long it's going to take everybody to read the operative procedure treatment, there's no type of delivery listed here. After everything else they've included, there's no type of delivery. And if you look at the bottom, so where I'm kind of rolling the cursor, they listed every single medication that they put the patient on. Personally, and first of all, why did they put the patient on an ACE, aka lisinopril? Now they could say, well, she was a late transfer of care, so this was by a previous provider. So that's potentially reasonable, but I would not list every single medication. The lisinopril, again, a little bit different just because it would be contraindicated in pregnancy. Personally, though, I would list oral antihypertensive medication. 24-hour urine protein, and then they listed, baseline was 276. It was all normal. So I would just put, preeclampsia labs or preeclampsia / pheochromocytoma labs, which would be even better. Well, what are pheochromocytoma labs? Well, I got metanephrines, catecholamine. I mean, that starts to promote a discussion. And since they have the patient with a pheo on the list, it's not like they can get away from it and not list it if they're going to list the pheochromocytoma. Growth scans and AFI at 32 weeks, Dopplers, weekly anesthesia. How about increased antenatal surveillance? And then they just ask you what that consists of. Insulin, labetalol, folic acid. I mean, folic acid would be routine anyway. So, listing the insulin, I'm okay with that. The labetalol, again, I would just put oral antihypertensive, but I would argue that that's part of the treatment at the bottom there. It's just a different antihypertensive. And if the patient had she had post-op severe hypertension, I mean, if she had IV antihypertensives, then I would put oral and IV antihypertensives. So, I mean, you can see the redundancy, with this patient: perinatology and genetics, increased maternal fetal surveillance, endocrine. Again, this might be a case. She is a CF carrier, so that's fine. But what about checking the father of the baby? Sister with spina bifida. Again, I understand, but in a case this complicated, I mean, do we want to talk about the genetics, or do we want to talk about the hypertension and what have you? My suggestion, if I were listing this case, I probably would take out the sister with spina bifida, in which case I would not specifically call out the folic acid, and the perinatology and genetics consultation. Um, Again, that could be because of the patient's advanced maternal age. So I would just, if the baby had spina bifida or had an abnormal AFP, if an AFP were done or anything on ultrasound that was suspicious, by all means, I'd put it in there, and I'd put in there about the sister with spina bifida. But otherwise, I would leave it out. She didn't end up having it. There's certainly plenty of other stuff going on with this patient. So again, would plan to leave it out. What other tests would a patient who has had bariatric surgery, what other tests should she have um, um, as part of her prenatal care? Would be another question that could come up. So again, this would be a patient that we could certainly pare down on some of the stuff. Um, um, the history of pheochromocytoma, again, good good topic to discuss. The patient already has chronic hypertension, so do you want to include that? Do you not want to include that? How did that specifically affect the management, other than the fact that the patient already has, in spite of the pheo, has a chronic hypertension? So we're still going to have to include the hypertension, obviously. If she had an active pheochromocytoma, by all means, you'd have to list it. The fact that she had one and it was treated makes it less critical to mention. All right, so if we look at this patient, this list rather, it's listed it's listed a little nicer, but it's not consistent. So if we look, patient number 5, okay, so this patient had a breast lump. Doesn't say anything about complete history and physical, which they seem to have listed for everything else. Look at patient 6, completed H&P, 7 and 8, complete H&P. So patient 9, given the fact that she's coming in postpartum, she didn't have a history and physical. What about a patient with dysmenorrhea? Do we only do a pelvic exam, no history and physical? What I'm getting at is you don't necessarily have to list history and physical. They're going to expect that you would have done a history and physical. So I would suggest that it's more um, that I would suggest personally that I wouldn't list complete H&P. But if you're going to list it for some, you better list it for everybody that had a physical exam. And if you didn't do one on patient number 10, kind of shame on you. I'm sure you did a history, and you may have decided to do a directed physical exam. But again, this is an example. While it looks nice and it is generally nice, you want to be consistent in terms of how you list it. All right, so more rules of the road. We talked about the less is more. So we talked about the PCOS versus listing every single lab, and we talked about listing management at a high level. So diabetic management, hypertensive management. We talked about the antihypertensives a couple of patients ago. Similarly, if you have a patient with a postpartum hemorrhage, there's no point in listing Pitocin, Methergin, Hemabate, and then going to your Cytotec and your tranexamic acid, etc. Better to list, the tranexamic acid is different, obviously, but aside from that, better to list uterotonics. Now, if the patient happens to be hypertensive, you're going to have to remember that you didn't give her Methergin because she's hypertensive, and it would be contraindicated. But listing every single antihypertensive really takes away from the case, and it's tedious to the examiner, and you're missing the basic questions that could be asked. So I would strongly encourage you not to do that. Similarly, if you had a patient with a shoulder dystocia, I would encourage you not to list every single maneuver you did. I'd rather you list shoulder dystocia maneuvers to discuss it at a higher level. Okay, so this will give you an example. So these are ones I made up. So you have chronic hypertension you see for this patient, postpartum superimposed preeclampsia. Now, please don't pay attention necessarily to the abbreviations that I used. We'll talk about abbreviations in a minute. But you can see baseline LFTs, 24-hour urine, ECG, protein creatinine ratio, nifedipine, serial growth scans, yada, 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 and so on and so forth. Okay, it's not wrong to list it that way, but my suggestion would be if you look at the bottom of the page and you see how the same patient is listed, much better to do it this way. We have hypertension management. Then we have oral antihypertensive. So yes, we gave her nifedipine, but they could say, well, what if the patient couldn't use nifedipine? What other antihypertensives could you use? And then you could say, well, I could use, labetalol. I could use Aldamet if need be. I mean, there's a whole bunch of, obviously things that I shouldn't say a whole bunch, but there are definitely other things that you could use. It's just, if you're less specific about it, it would promote the discussion. So, they have misoprostol for the induction. I put cervical ripening. I think that's better, whether you use a balloon, whether you use misoprostol, kind of who cares? If the patient were a prior C-section, obviously the misoprostol would not be indicated. And again, this is all something you would verbally discuss with them rather than having listed everything. Now, the IOL is induction of labor. So I would argue that that is something that you could list. And instead of mag sulfate, I put seizure prophylaxis. So seizure prophylaxis is definitely, basically it's the same thing, but it's a higher level listing. I mean, what do we use for seizure prophylaxis? Well, 99% of the time we use mag sulfate, but the question could come up, well, what if she were allergic to mag sulfate? Or what if she had myasthenia? Okay, well, then you'd have to talk about, whether you're going to use phenobarb, whether you're going to use dilantin, are you going to use a benzodiazepine, whatever. But again, it can promote discussion. So I definitely prefer the way the second one is listed. It's less specific, it promotes discussion. And this is an example of kind of what I was talking about. Now, on the old quid pro quo. So for every complication you have on your OB list, you should have something in your procedure treatment column to correspond to it. So I'm going to say that's true in probably about 95% of the cases. Also, you want to try to make it very reader friendly. So try to line up your listings chronologically and or by condition. This would be both on the OB and the GYN lists. So for example, patient is a gestational diabetic and she's advanced maternal age. Well, I would list advanced maternal age first because when she came to you, she was AMA, obviously. And the gestational diabetes wasn't discovered probably until the second trimester, or perhaps the early third trimester. So again, listing it chronologically. If she, developed fetal growth restriction, that would be, again, something later in pregnancy. So that would go further down. And then when I put my treatments for this, the first thing would be genetic counseling or genetic counseling declined or genetic testing or whatever. Then the next thing I would be, diabetic management or, and if she required medication, I would probably list insulin after that. And then for the growth restriction, I would put, increased antenatal surveillance. And if you want to list growth scans separately, by all means. So again, you'll see in a second an example of this. So let's look at the first patient. So AMA. So this is what I mean by the quid pro quo. So she's advanced maternal age. So we want to address that in the procedure treatment. In this case, I put genetic counseling. Now, she may have declined it, but at least if you list genetic counseling declined or declined genetics or something, you're saying to the examiner, okay, I recognize the AMA, I diagnosed it, and this is what happened. She didn't want testing. Or you could list, if she had an amnio, you don't have to list everything leading up to the amnio. You could just put amniocentesis normal. Or you could put CVS. Or if she didn't have that and she just had NIPT, you could list that. You don't have to list every single thing she had. In fact, I'd only list one thing. I would list the most diagnostic or invasive thing she had. And if she didn't have anything and you just did counseling, then I would just list the counseling. If she didn't have counseling, I would say, just put declined. Now, I made this patient hypothyroid. So you can see in the procedure treatment, I put thyroid replacement, or you could list hypothyroid management. We'll talk about it in just a second, but I think the hypothyroid management personally is the better way to list it. Now, again, based on my template here, it's a little hard to kind of line things up so that the hypothyroid is, across the same line, if you will, as the thyroid replacement. But what you can see is they're in order: AMA, genetics; hypothyroid, thyroid treatment. She was PROM. Okay, so we had to induce her. You can see by the colors here that the PROM resulted in the IOL, induction of labor. Now, maybe it was cervical ripening and then induction of labor. Maybe it was just Pitocin augmentation. Doesn't really matter. And then, of course, I have the type of delivery. Now, if you look at the next case, it's the same patient, AMA, hypothyroid, and PROM. Okay, so it's still only one diagnosis per line, which is great, but it's, they're bunched together. Again, it's still easy enough to read. But what's the problem here? Well, first of all, I haven't addressed the AMA, so my quid pro quo is out the window. I have induction of labor and the vaginal delivery and then it's almost an afterthought that I listed synthroid. So I really don't like the way this case is listed. First of all, it's out of order in the procedure treatment, but more than that, I put synthroid on there. If anything, I would put thyroid replacement. But quite honestly, I like how the patient above was listed, where I put hypothyroid management. So why? What does that include? Well, it would include thyroid replacement for sure. It would also include potentially a growth scan, because these folks are at increased risk for fetal growth restriction. It would also include checking at least a TSH at least or every 4 to 6 weeks, or if they're completely stable, perhaps once per trimester. But it'd be all three components. It's not just the medication. So again, but it's all wrapped up into one nice, neat phrase, which is why I prefer this case and specifically this listing. I don't like the second listing because, again, I mean, it's okay, but doesn't really address the AMA at all. Doesn't talk about what labs I got, which again, you don't have to list them specifically, but you'd want to promote the discussion of how often you would check thyroid functions, which ones you check, what if the patient were hyperthyroid, which thyroid function test would you check, and would your interval be different? Okay, OB do's and don'ts. I think this is where I got fancy with the blend-in. So the gravida should be one more than the para. So really don't like to see patients on people's lists that are G1, P1s in the OB section, assuming they're pregnant. Now, if the patient just delivered and you're listing her as a G1, P1 because it says SVD on there, that doesn't fly. The patient really should be at least 6 weeks beyond before you would add the parity in from a list standpoint. So if you have just deliveries listed, even if it's including the postpartum care, generally speaking, it should be, I would count the current pregnancy or the maybe just recently completed pregnancy in the gravida, but I would not count it in the para. So G1, P1, no. G1, P0 is possible if this is her first pregnancy. G2, P1 if she's had one child before. Again, the only time you would see like a G2, P2 would be if, let's say she's currently pregnant and the last pregnancy was a set of twins. Now, obviously, this doesn't carry over to the GYN list. This is just for the OB list. Okay, I think we just talked about that. Please make sure you list the type of delivery. I can't tell you how many lists I've seen over the years where people, you can almost guess what kind of delivery patient had based on the length of stay, what have you. but you don't really know, you're really guessing. So the examiner clearly cannot understand and put together the night before what happened with this patient. It's sloppy and it's perceived as careless. For any shoulder dystocia cases, they are not spontaneous vaginal deliveries. I'm sure we've all done shoulder dystocia patients, and we know that the delivery is anything but spontaneous. So I would just list it as a VD or vaginal delivery. And then usually you're going to have to add shoulder dystocia maneuvers. Okay, so if you had a patient, let's say that's admitted at 33 weeks for PROM, and you admit the patient, you give her steroids, you start her on latency antibiotics, and 2 days or 3 days later, she goes into preterm labor and delivers, and your partner's on. So you would list the patient because you admitted her. You could do you would not list baby information because you did not do the delivery. You shouldn't list baby information if you didn't do the delivery. But you could put SVD at making up the gestational age, 33 and 5 by partner or by colleague. So that's how you would list that. If somebody had prenatal care by, let's say, an outside group or somebody else, certainly you could list that. If the prenatal care they provided is exactly what you would have done, I would not specifically call it out. I would only call it out in situations where the prenatal care or the delivery or whatever was done differently than you would have done. I'll give you an example. Let's say you cover residents, you're on duty at 5 o'clock, and they say, hey, we've got a lady that's 6 centimeters, we're inducing her because of her husband's being deployed and she's 39 and a half weeks, whatever. So you go to check her when you come on duty because, you just want to see if it's your same 6 centimeters. And what you feel, you're not sure that you're feeling vertex. You scan her, lo and behold, she's breech. So your list reads, Pitocin induction, breech, C-section. You'd be like, holy cow, why were you pitting a breech all day like that? So what you'd say is, you could list that the prenatal care was done by your colleagues. Or I'm not sorry. You could say that some of the intrapartum management was done by your colleagues. But honestly, I would leave it listed as what I had just said in terms of the C-section. But this would be a pertinent positive. Hey, when I came on duty to cover this patient, I checked her. I wasn't certain what I was feeling. I did an ultrasound. Had I been inducing the patient from the get-go, I'm making this up, I always do an ultrasound to be certain the patient is vertex. So that would be a way you could verbally explain it, but that would be one of those pertinent positives you keep in that separate notebook that I was talking about. Include the number of prior C-sections. So we always have people that have repeat C-sections. That's fine, but it's important to know the number. And just because somebody is a G3 P2 doesn't mean she could have had one prior section and one prior vaginal delivery. She could have had 2 prior sections, and it makes a difference in terms of what you did or didn't do in terms of the treatment. So please make sure you list that. For a patient that's obese, don't just list obesity. There's a big difference, no pun intended, between a BMI of 31 and a BMI of 41 in terms of your management, the risks, etc. So either list the class, so class 1, 2, or 3, or list the specific BMI. So indicate labor or reason for the delivery for every patient less than 39 weeks. So if the patient came in labor, let's say she's 38 and 5 and there's really no complications, I would just put labor. Okay, well, that's why she delivered at 38 and 5. If she came in PROM, fine. If she's being induced, you'd have induction in your procedure treatment, and maybe she's, she would have the complication in the antepartum. It might say fetal growth restriction. It might say preeclampsia, and let's say she's over 37 weeks, or maybe preeclampsia with severe features. So you started inducing her earlier. That would be in your diagnosis. You wouldn't say induction for preeclampsia. We'll be able to figure that out. But the labor, the PROM, SROM, these would all be things that are important, especially for patients that are less than 39 weeks. Okay, so let's look at some of these. So you can see here for the first patient, I have class 3 obesity, or you could put BMI of 44. Now, obviously in your list, it's not going to say 38.5. It's going to say 38 W4D, like 4 days or something. Um, you can see in my quid pro quo, I have weight management for the obesity, which I would encourage you to discuss. I mean, were you doing any increased antenatal surveillance? How did you counsel the patient regarding appropriate weight gain, the risks of obesity? So that's my high level capture there. Now you see this in this first example, I put McRoberts, suprapubic, um, um, suprapubic, and then Woods and suprapubic. I'm not sure what the man part there. I think that's a typo. Sorry. Woods, screw maneuver, Rubens, and then delivery of the posterior arm. So, you can list that, but what's the point in them asking you now what you did for this patient? I mean, it's in black and white. Rather, I would have rather that said weight management. Then I would rather it have said shoulder dystocia. I'm sorry, vaginal delivery, shoulder dystocia maneuvers, not the SVD. So the SVD should come out here. The next patient, she's a G3P2. So I put prior CD ×1. She declined Tolac. Okay, great. Repeat C-section. So this case is listed fine. Now, some people will offer a prior section ×2 a trial of labor, some won't. So, but we all should be offering patients with one prior C-section, as long as it's a low transverse, a trial of labor. So again, useful information to put here, because she could have been a prior ×2, and maybe your hospital doesn't allow prior ×2. If we look at the next patient, you see that she had preterm labor and fetal growth restriction. Again, since I didn't have a length of stay to list for the baby, because my document wouldn't go out far enough column wise, that's why I put the NICU stay times 50 days and the delivery complications. Normally, it would just have a length of stay for the baby, which would say 50 days. You can see I put antenatal steroids. I did not list, dexamethasone or whatever. GBS prophylaxis, I did not list penicillin. Antenatal surveillance, okay, so what was that done? Then I have SVD by colleague at 31 weeks. You can see I don't have any baby information, so this is appropriate management or listing here. Okay, so again, indicate labor or the reason for delivery for every patient under 39 weeks. Your complication would say preeclampsia, and the procedure would say induction of labor. And again, the preeclampsia would be typed out. So if you have an IUPC that you've placed on a patient, please list it. You should, and you want to be consistent about this. So for all arrestive dilation or arrestive labor disorders, should have an IUPC. That doesn't necessarily hold true for arrestive descent. It's just for the arrestive dilation, so somebody in the active phase of labor. If you have a patient that has a 5-minute APGAR less than 7, list the 10-minute APGAR in the delivery complication column, and/or you could list the cord pH and base deficit and be able to explain your interpretation thereof. If you have a patient that's readmitted, if she's coming back to the same hospital, we'll show you how to list that. If it's a different hospital, but you still took care of the patient, you're likely going to have to list the patient twice, because to get the hospital sign off, you'll need to list the, you'll need to have that patient for each hospital. But in that case, I would put same patient as OB22 or whatever. Again, that's only if they're admitted to different hospitals during the collection period. So we're going to look at an OB admission and a GYN admission on the same patient. Again, if she delivered, if she delivered and you did the delivery, you should list her on your OB list unless she was completely uncomplicated, aka delivered between 39 and 41 weeks without any and delivered vaginally and had no complications. That's a patient you don't have to list on your OB list, period. So you could put her on the GYN list. But if she needs to be listed on the OB, because let's say she was preeclamptic or hypertensive or before 39 weeks, whatever, that's where you would list her, and you'd want to put the GYN admission on the OB list as well. Again, if you didn't deliver but had the OB or GYN admission, you can list her on either section. If you did do the delivery, list on the OB again, unless completely uncomplicated. So, so again, if she had an OB admission, like the patient that was displayed before who came in at 29 weeks or whatever with rupture, that would be a patient you'd actually have to list on your OB list. And whatever GYN, you'd have to say, readmitted 3 months later for tubal ligation, what have you. So if she was only brought in, this should really be if she were only brought in for observation on OB, you can list her. You could list her on either section. But if she were only brought in for observation on OB, so in other words, she's brought in for less than a day, and she had a GYN procedure, I wouldn't list her on OB, and I would list her on GYN. Sorry, that's a little confusing. All right. We're in terms of where to list things on your OB list, any complication or problem that happens up until the time you write the admission order, so admission to labor and delivery, should go in the antepartum column. Any complication that occurs during labor or once the patient is admitted through the postpartum period should go in the delivery postpartum complication column. We shouldn't be seeing arrest of labor in the antepartum column. That would be an issue that's, a delivery complication. You don't need to put information, be so specific like how far dilated the patient was when she had an arrest of dilation. Nobody cares if she was 6 versus 7 versus 8 versus 9. Doesn't really matter. She's an arrest of dilation. So please don't include that extra information. For your abnormal tracings, you need to categorize the tracings. So some people are uncomfortable with just putting category 2 tracing. They want to define it more, so they might put category 2 tracing with deep variables. That's fine as long as you list the category 2 tracing. We shouldn't see non-reassuring fetal heart tracing. We shouldn't see, by itself without a category assigned to it. Terminal bradycardia, again, fine, but categorize the tracing. Hopefully for all your category 2 tracings, you attempted intrauterine resuscitation. And if you did, you can list that in your procedure treatment, intrauterine resuscitation. If the patient ended up with a C-section, I would put it as failed intrauterine resuscitation. If she delivered vaginally, I would just put intrauterine resuscitation. Again, make sure your use of all terminology is correct, again, especially for the failed induction that we saw earlier, and the arrest of dilation or labor, as well as arrest of descent. As we talked about, you can't have both a failed induction and arrest of descent, or a failed induction and an arrest of labor. Okay, you can see this a little bit tedious. Arrest of active labor at 6.5 centimeters. Who cares? She's an arrest of active labor. You had the IEPC, that's good, because that's how we made the diagnosis. And we have labor there as an antepartum complication. It's not technically a complication, but what we're showing the examiner is, hey, this was not an induction I did. This patient came in spontaneous, with spontaneous labor. Next patient, PROM. Okay, so she ruptured her membranes before actually going into labor. So gave her Pitocin. You can see here, the primary C-section, and I've seen this a lot on people's lists, is listed in the delivery postpartum comps. No, it's a procedure. So that really should go in the procedure treatment column. The arrest of second stage should go in the delivery or postpartum column because she was already admitted. And we don't care that she was arrested at +1 station. So this really should just say arrest of descent in the delivery postpartum complication column. All right, so let's look at a few others. AMA and latent labor. So we have NIPT normal, and you can see that's matched up in terms of it's matched up from an alignment standpoint. Then we have latent labor, so I have labor augmentation. Okay. Then we have category 2 tracing. So you can see next to it is the intrauterine resuscitation. And it's not a failed intrauterine resuscitation because the patient ended up with a vacuum-assisted vaginal delivery. But you do see the APGAR as being low. So you can see I've listed the 10-minute APGAR of 9 in the delivery complication column. And of course, I've just made you all seasick by scrolling with my mouse instead of hitting the return button. All right, so the next patient, 39 in, let's say, 6 days or 4 days, whatever. Postpartum preeclampsia, again, please don't go with that abbreviation necessarily. I don't think it's an approved one. The IOL may not be an approved abbreviation, but everybody's going to know what we mean by IOL in the context of where it's listed. So we have induction of labor, vaginal delivery, and then we have, you can see how they're aligned here. Postpartum preeclampsia, so she was readmitted postpartum day 4 for preeclampsia seizure prophylaxis. So I think that's a nice way to list it. It's easy to read. It all lines up. Patient number 18. This is another way to list the patient. Postpartum day 4, status post SVD by colleague with postpartum preeclampsia. Now, we don't need to know all the complications that the patient had, like she was diabetic or she was this or that during the antepartum, because we had nothing to do with the antepartum except maybe providing prenatal care, but we didn't have anything to do with the admission or delivery. What we took care of at this point was the postpartum preeclampsia, and we see seizure prophylaxis. Mind you, there's no baby information because, again, she was already delivered and we didn't do the delivery. If we had done the delivery, we would list obviously the delivery, and then we would skip a line with the, readmitted 4 days postpartum for preeclampsia is how that would be listed. Now, here's the situation where a patient had a GYN procedure and she had a vaginal delivery. So she really needs to be on the OB list, but I wrote status post LEAP for CIN3 with negative margins 2 months prior to conception, and then the labor, and you can see how it's listed. So we have both admissions. Now, obviously, this is assuming they both occurred at the same hospital. Now, let's look at the next one, because so that's an example for the dual procedures when we want to list it on the OB section. Punctuation. People use a lot of punctuation. Some faculty folks are going to suggest using punctuation. Punctuation is okay as long as you only use it 1 or 2 times per section, but it's if you're using it on every case, it's very tedious for the examiner, and they may actually go to the point of not looking at your cases where there's punctuation. This, I would argue, is an appropriate use of punctuation. It says cerclage, and then it says no history of second trimester cervical dilatation. So she's a nulliparous patient. So why did she have a cerclage placed? Now, if we look at this, it says prenatal care at outside facility. Ooh, thank goodness we didn't put the cerclage in. And also, why wasn't it removed before 40 weeks? Again, she had prenatal care at an outside facility. So it's drawing attention to it, but your defense really is the prenatal care at the outside facility. What I would say is, look, had I been managing this patient, I would have recommended her cerclage come out at 36 or 37 or whatever, whenever you remove it. And quite honestly, without a history of preterm delivery, or need for a rescue cerclage, aka dilated and effaced in the second trimester, or an incidental shortened cervix found on ultrasound, and I'd be able to define that, aka less than 1 centimeter, I would not have even placed a cerclage on this patient. So, again, the prenatal care at the outside facility really kind of helps you in this case. And this is appropriate use of the punctuation because it is an unexpected thing that she should have had a cerclage in the first place. All right, so let's move on to some GYN. So, how to list multiple procedures occurring on different days. We'll go over that. Try to line up info that goes together. So again, abnormal bleeding, we want to try to align that with the DNC hysteroscopy in the procedure. And we try to line up the pathology in the, meaning, let's say, benign endometrium in the pathology column. You want to make sure you have EMBs, and you can use the abbreviation EMB in all caps, or DNCs, so some sort of endometrial sampling for all abnormal uterine bleeding related hysterectomies or ablations. An ablation has to have pre-op sampling before you do the ablation. If not, that's a huge red flag. You want to know what contraception ablation patients are using post-procedure. I talked about that a little bit earlier. So pertinent positives and important negatives. That would be something I would, if you don't list it specifically on your list, that would be something I would note in that notebook I was talking about that you can rehearse from as you're preparing for your test. So again, you can leave it off, meaning the form of contraception, but then you're going to need to know it kind of on the spot so it doesn't look like you're making it up. When I say on the spot, I mean you without hesitation if they asked you what she was using for contraception. So please shorten your pathology and radiology reports. It's extremely annoying to read, excuse me, that someone, the dimensions in centimeters and millimeters of someone's uterus, which is normal. And even if it's abnormal with fibroids, I mean, it could say 14 centimeters with multiple myomas, largest 6 centimeters. I don't need to know that she had one that was 6.2 by 5. It's too much information. Um, so for your pathology, you do want to account for each organ that was removed, however, but you can list it as benign. If it's squamous metaplasia, as I mentioned, who cares? Inflammation, who cares? We're looking for, more serious pathology. No need to list consults where no procedure was performed. So if you're called to see a patient with abnormal bleeding in the hospital who's on the medicine service and you don't do anything except to say, write a consult and say, hey, have her follow up with me in my office upon discharge, you don't need to list that patient. Now, if you see a patient in the ER, or if that same patient I was talking to you about that was on the medicine service, and you did an endometrial biopsy on her, let's say in the treatment room, that would be a patient I would list. If you see a patient in the emergency room who's either admitted or goes to surgery or has some sort of procedure, again, that would be a patient I would list, but I would confirm all this in the bulletin. So again, inpatient hospital consults on other services, you don't necessarily need to list. Intra-op consults, you absolutely need to list, even if you just went in and was a peek and shriek and, or you said, hey, I think she'd be better off, treated, whatever. If you rendered a consult intra-op, that would be something you would want to list. All right, so let's look at consistency. So again, consistency is very important. So we look at patient one, she's abnormal uterine bleeding, endometrial biopsy benign. She's had a history of a BTL, perfect. There's no pathology here because all we did was the ablation. So that looks good. Patient number two had abnormal bleeding, endometrial ablation. Oh, where's the biopsy? Well, she's only 38. Where's the biopsy? Got to do the biopsy, even though she's only 38. So this would be a problem. Patient number three, abnormal uterine bleeding, failed medical management, DNC hysteroscopy, endometrial ablation, endometrial curetting benign. So that's fine. All that's fine, except there's still no endometrial biopsy preoperatively that was listed. It's not good enough just to do the DNC hysteroscopy, even though you're getting a sample of tissue because you did the ablation. Now, if you did the DNC, and then 2 weeks later did the ablation, fine. If you did the DNC and sent it for frozen, not as good, but okay. But if you didn't have any pathology before you did the ablation, that's a problem. All right, let's look at the next case. So CIN3, abnormal uterine bleeding. So she had a LEAP DNC hysteroscopy. The LEAP showed negative margins and the curettings were benign. The patient desired definitive treatment. I hope you can see how this is lined up nicely. So she had a TLH bilateral salpingectomy with the pathology. Now you can see the uterus, 200 grams, multiple myomas, benign, cervix, endometrium, tubes, benign. So again, the pathology here is very brief, but it's complete. And I think that is it for this one. All right. So one entry or diagnosis or problem per line, don't put abnormal uterine bleeding, pelvic pain, and it's all kind of one big run on. It's very difficult to read in that case. Your length of stay for outpatient procedures is 0. On GYN tests, so labs like tumor markers, if they were done and you want to include sonogram CTs, go in the pre-op column. So all your failed medical management goes in the pre-op column. Only the surgery in that case or the inpatient medical treatment would go in the treatment column. Again, we talked about being selective in terms of what you list. You may choose not to list tumor markers for a given patient. So, okay, leave them out. If they ask if you did them, by all means, I would say yes. Obviously, you're going to be honest. Please don't list all dimensions. I kind of talked about that before for the size of the uterus or ovarian cysts. Just list the biggest dimension and you can round up or down. no millimeters, unless we're talking about endometrial thickness. This is another important thing. I can't tell you how many people I review that have quote unquote thickened endometrium, because that's what the pathologist, or sorry, radiologist has reported in a non-menopausal patient. There is no such thing as a thickened endometrium. The only thing we're interested in those cases, as far as the endometrium goes, is is it homogeneous or heterogeneous? Because that would make us suspect perhaps a polyp or no polyp. So here again, you can see 25-year-old abnormal uterine bleeding, pelvic pain, sonogram. You can see 8.2 by 6.9 by 5. I mean, is that really giving us any information? Thickened endometrial stripe. There's no such thing, 1.2 centimeters. You can put the endometrial stripe, but please don't put thickened. I would argue that it's really irrelevant unless it was something outlandish like 2 centimeters or more. I probably wouldn't even list it. Heterogeneous, I would definitely list it. Not necessarily the thickness, but at least the heterogeneity. Now, the right ovary, look at the dimensions here. Does it really matter? I would just say 6 centimeters, 7 centimeters, whatever. DNC hysteroscopy and a diagnostic laparoscopy. So there's no pathology. We didn't see anything. So you'd want to know at least you did see the cyst, didn't see the cyst. And if you didn't see the cyst, if you did see the cyst, how come you didn't take care of it? The next patient, so you can see this is lined up a little better. This is more concise. It's the same patient. Abnormal bleeding, pelvic pain, ultrasound, and the ultrasound is, again, more simplified, much easier to read. All right, office do's and don'ts. So you can only have 40 patients. Every year I get 1 or 2 people that, put in 41, 42, and then they'll have 3 cases under one section. No. 40 cases, period. You can only have at most 2 patients in any given category. You could have 1 patient in each category for 40 patients. You can have 2 patients in each category for 20 patients, or you can have a combination thereof where you have some patients categories rather that have 2 patients and some that have 1. But when it's all said and done, you should have at least 20 categories and you should have exactly 40 cases. So please don't throw in an extra patient. All right, this is going to be one of my 2 biggest points of the whole day. Please do not pick out the quote unquote most interesting case for your list. Every year I get somebody that, puts on primary amenorrhea, who's not a REI or a pediatric GYN, or they put on ambiguous genitalia or something, really weird that they're not going to see except for maybe 1 or 2 times in their career, if that. If you're an expert in the condition, fine. You want to put it on there, go for it. But if you're not, this is, you might say, oh, that's an interesting case to discuss. Yeah, it might be, but you're going to spend 3 days learning about it and how to present it and have to memorize it, not to present it, but how you worked it up and how you, and memorizing it and all that kind of stuff. You don't want to invest that much time in any one case, not to mention there's 2 schools of thought. One is they may ask you about it because it's so unusual, or 2, they may not ask you anything about it, figuring you're going to be an expert on it, or you wouldn't have been so foolish to list it on your list. Please don't pick the most interesting case. Number of visits. So for the problem listed, so, if you saw a patient, 8 times during the year, 2 of them were for yeast infections, which is what she's listed on under your list. 1 was for a well woman that no yeast infection seen. 1 was for, a lump she found in her breast. Again, nothing seen. Just put the 2 visits, which again would account for, the problem that you're addressing and that you've picked up. Don't have 2 similar patients in the same category. So every year I see people that, they have 2 patients with BV under vaginal disease. Yes, both patients will count, but it's not adding any breadth to your case list, any variety that the examiner might consider asking you about both cases, or they may not ask you about either case. Again, if you have 40 cases, 20 topics, and each topic has similar patients under it, that's very limiting in terms of what the examiners can ask you. And they're more likely to deviate from your list and say, well, let's say instead of a yeast infection, because you have 2 yeast infections, she had trichomonas or something else. Again, that's not the worst question in the world, but they certainly could deviate from that more than the case of the vaginal discharge. The other scenario I would say is, preventive health or well woman visit. There's no point in having a patient who's 25 and a patient who's either 28 or 33. They're in the same quote unquote age band. you're better off having a 25-year-old and a 55-year-old, or a 38-year-old and a 65-year-old, because the tests that would be recommended, the vaccinations are different. So it gives them something more to talk about. Again, two very similar patients in the same in the same category, I would not recommend. And similarly, I've had people that had contraceptive management. So one, they put a Paragard, one, they put a progesterone IUD. Then, they had a patient with abnormal bleeding, so they had another progesterone IUD. And, or they had somebody with hyperplasia, and they had another progesterone IUD. So I've seen, lists where they've had, patients, 4 patients with BV, or 4 patients with the same IUD. And it's like, again, it's a very narrow list, and they're going to have to come up with other topics, which you won't necessarily be able to predict, because again, it's not on your list. So you're shooting yourself in the foot by doing that. You're not giving them enough variety to choose from to ask you questions. Now, what to do in the results column? Some people put in the results column patient improved or ongoing care or whatever, and some people actually list the results of the tests they did. Either is potentially acceptable. If you're doing tests, I would suggest just put tests normal and just call out the abnormal ones. So if you had a patient that had PCOS labs and they're all normal except for the testosterone, I would just list testosterone and list whatever the abnormal value was. Now you could do that. You could do that in the results column, or where you have listed the PCOS labs, you could just put in parentheses testosterone. In other words, you could list the actual result in the testing column, or the diagnostic procedure column. So here, same case and most interesting case. So that just an example, vaginal discharge and itching, you can see both 20 and 21, very similar patients, almost not exactly the same age, but close. Oral antifungal medication. Okay, not an exciting case to begin with, and we've used 2 cases to talk about the same condition. Patient 22, primary amenorrhea, labs and ultrasound. Okay, it's high level, progesterone withdrawal, cyclic birth control pills, thyroid replacement, endocrine referral. Okay, but the whole thing is, well, what's your differential for primary amenorrhea? I'll give you a hint. There's 17 different causes. How would you work it up? Well, there's 4 categories they could fall in. I mean, this was my nightmare scenario question, and doggone if I weren't asked about it during my exam. But I knew it was my Achilles heel, so I had studied for it, but this would not have been something I would have voluntarily put on my list. Okay, you can use it. These are general comments. For your list, you can put things like no contraindication for mag sulfate to promote discussion on your list if your list is short and without much patient variation. So I have some people who only have 20 cases, for example, for their OB. So, and they're not super exciting cases. So you can try to promote more discussion by using the, no contraindication, or, GBS, no penicillin allergy. Again, attempting to get the examiner to say, well, what if she had a penicillin allergy? How would you manage it? You want to do that in moderation. If you overuse that technique or any other technique like the punctuation, etc., the examiner is going to understand you're trying to point them in a particular, to a particular case or a particular topic, and they may choose to just ignore it completely. So again, some faculty from Exam Pro will say, you can use things like concern for. Again, that's fine. You can use that in lieu of rule out, but again, only 1 or 2 times on each section, not 10 times on a particular section. Same thing with punctuation. Punctuation can be good, but it should be something really unexpected and unusual, not something routine. I've seen people just put it on everything, and it's like you just want to stick a pencil in your eye when you're reviewing them. It's not only tedious, but it's like, what the heck are they trying to point out, or what have you. Emboldening print or using all caps, I would recommend not using those techniques. It's monotonous to review. I had one person that had their whole list in caps. It was like, oh my gosh. very, very annoying to read, and I can't help but to think the examiner is going to feel the same way. So again, don't use all caps. If you need to use it for one word, fine, but not for the whole case entry. Emboldening print, so putting something in um, bold font, again, for one word, whatever, um, or a phrase maybe, but one or two cases if it's really unusual, and that would be it. Audit potential, so it's highly unlikely they're going to audit you. But if I were the auditor and I came to your hospital and I said, hey, can you pull all of Dr. Jones' patients or charts? The question you need to ask yourself is, would this patient come up? If it's yes, but you provided no care. So let's say, you were the attending of the month, but you on OB, but you went away for the last week of June. But the admitting folks, just had you on for the whole month. Okay, you could say, hey, look, I was out of town then, I can prove this. So, that'd be fine not to list that patient, but you want to make sure if they go to audit you and they say, hey, give us a list of all Dr. Jones patients, that you have all those patients on your chart, again, assuming you provided care for them. All right, so in summary, consistency is critical. I showed you several examples where people included ablations, didn't have ablations, whatever. You must be consistent. So EMBs for all ablations or hysterectomies for, in the case of hysterectomies, for all abnormal uterine bleeding, but definitely for all ablations or some sort of pre-op sampling. You should have listed, assuming you used one, an IUPC for all arrest of labors. Again, not necessarily arrest of descent. For your office list, don't pick the most interesting case, and definitely only have 40 patients with a maximum of 2 per category. Be concise when you list your patient. Not every detail should be listed, but enough so the examiner can understand what happened to the patient and the treatment when they're looking at your list the night before to query you the next day. High-level terminology is good. Again, less specific promotes discussion. Uterotonics, shoulder dystocia maneuvers, PCOS labs, diabetes management. Definitely would encourage you to consider being high level. Last thing, start working on your list now. You will thank me when it's done and when you're caught up. I mean, trying to practice, have family obligations, whatever, and put your list together. And you're going to have to start studying earlier because you don't know if you're going to be an October candidate. You will really be thankful if you only have a few cases to add. There's no reason you can't get your office list together at this point. You could certainly enter your GYN and your OB up to the time that you're viewing this webinar. Consider again having your list reviewed. One of the things we look for is similar patient but treated differently. Why? So sometimes people get stumped with those. We also try to suggest questions that could be asked during the test. Of course, we proofread for missing information, including things like type of delivery, as well as spelling mistakes. So that is it for my suggestions. Again, you're going to hear from Dr. Shamroth, of course, and Dr. Foley. They may have a slightly different take,